So it's a pleasure to present to you the next speaker in the XtraTracks. This is Rüdiger Pryss, who is Professor of Medical Informatics since 2019 at the University of Würzburg. And as he addresses relevant research in the field of smartphone sensors, ecological momentary assessments, mobile health, and has published renowned studies in that field. We are happy to have him here with us to give us some insight in that part, as well as his experiences in terms of regulatory requirements and affairs. So welcome, Rüdiger. The slides are yours.
Okay, thank you so much for the very nice introduction. So yeah, the idea for today will be to share a little bit what we are doing with our mobile research that we are doing now for over 10 years. And we have developed a lot of apps for different medical entities, for a lot of studies. And so we learned a lot and we started with ecological momentary assessments. You have mainly the topic here of biosignals and also of imaging that are done with mobile devices. This is not that we have a long history with this, but also sensor technology plays more and more an important role in our research. And I want to give you an introduction and also a little bit of information what we are doing and what is also our experiences there, and hopefully to give you some insights of the working group. So also to share this information, the professorship is on the one side at the University of Würzburg and also on the other side at the University Hospital. So I'm also involved in the medical field very deeply with all the clinic side. And this is also a very lucky situation for me to see how this is or can be embedded in the whole medical field, what we are doing on the research side. One advertising slide. So you see here what the group on the picture on the one hand, and what is important or what I want to emphasize is that in the last years we are doing more and more research in the field of ecological informatics. So meaning that you're using the smartphones in everyday life. And if we are collecting data in everyday life, so many things are changing. This was also the reason why we started to use artificial intelligence methods to analyze this data, but many other important aspects. But if you are collecting data in the wild, then things are often changing. And this is things that are done by the group and what we are targeting at. Most of our research is also provided by videos that we have on this website to also guide you to this website. If you're interested in our projects and have a little bit of more information, then here this website is providing a lot of information. What will be the agenda for today? As patient-reported outcome measures, this was not in the title, but here in the agenda it's very prominently shown, and I think it's important to have some running up on patient-reported outcome measures and combine this also with the idea of ecological momentary assessments, because the reason why I want to do this, often in practice, many things are going wrong, and many researchers and also companies are disappointed when using smartphone apps in the medical field and why it's not working. And many aspects why it's not working is affected or is coming from these two disciplines or concepts. And I want to say something about this. And then on a practical example, this is then my agenda point, the journey. I will give you one project and a long journey that we are doing for now over 12 years. And what is the outcome of this journey? To give you a very good, I think, insight, what are the problems. And then I want to also show a very recent project. It's the acronym is very hard to understand, but you will see what is behind this acronym, and then I will do some final remarks in the end, what are important messages, what we have learned. Yeah, patient-reported outcome measures. I like to put the patient-reported outcome measures into ChatGPT and asking ChatGPT what he or it is thinking what patient-reported outcome measures are. The reason why I like to ask ChatGPT, because ChatGPT is creating a picture that is mainly not that the main aspects you want to achieve with patient-reported outcome measures. In essence, patient-reported outcome measures are the idea that the patient, him or herself, is reporting the symptoms, so that not the doctor or some medical expert is gathering the symptoms. The patient, him or herself, is reporting the symptoms. And the important idea is here that if the patient is doing it him or herself, then it's more honest and it's more accurate. And what ChatGPT here is showing, that we are doing it patient-reported outcome measures in the clinic or accompanied by a medical expert. And this is not what we want to have, because patient-reported outcome measures shall be done without any medical experts accompanying the filling out process of the symptoms by the patient, because then it's more honest and it's also more accurate. So what ChatGPT is showing here is not okay, or it's okay, but it's more the whole concept then is getting powerful if the medical expert is not accompanying the filling out procedure. And why is it that important at the moment, the patient-reported outcome measures, the opportunity behind it? First of all, David Bates, very important person from the States that is doing digital health. This is a publication of him, a recent publication, saying, and this is for many more indexes at the moment, the case that clinics all over the world now are also evaluated based on their abilities to have patient-reported outcome measures in their clinic. So in the ranking, you are getting up or down if you are providing patient-reported outcome measures or not. So this is a criterion showing that it's very important. And why it is important? Patient-reported outcome measures have shown in many cancer studies, here very prominently, that it can extend your survival time. So if the patient, him or herself, is reporting the symptoms, then your survival time is increasing. What a remarkable result here. And this is also the reason why we learned that patient-reported outcome measures become or are very important for clinical research and also for daily life situations in the whole medical field. If you have a broader look at patient-reported outcome measures, then this has also a longer history, starting 20 or 30 years ago. And you see here on the whole timeline, for example, that in the States, 2004, a lot of money was put into this research. And we are still in the situation that patient-reported outcome measures not a common instrument in clinics or in research, but there is a longer history. Also, the Charité, a very renowned researcher in this field, is Matthias Rose, who was coming back to Germany in the Charité, doing a lot of research here, and also showing that this is very important. And the Charité has also announced that this is one of their important fields in the next year. So patient-reported outcome measures everywhere are very important. And this is a very simple thing, that the patient is reporting him or herself. But this is a global trend. But now comes the but. Here the announcement is in German, but many of the digital health applications, the apps on prescription that started in Germany 2019, a lot of these companies have the problem that they run into bankruptcy. And they are also doing a lot of patient-reported outcome measures. And many of the medical smartphones, most of them are doing patient-reported outcome measures. And the question arises, why is it that? Why are the companies getting bankrupt? And also many problems arise here with a simple instrument that you report your symptoms yourself. And the first reason, the first challenge is that the concepts that are out in research are not very well distinguished. If you have a look at patient-reported outcome measures, then, as I said, they want to mitigate the observer bias. The observer is the medical expert, is on your side while you're filling out your questionnaire, and this should be not the case. The medical expert should be away so that you are reporting more honestly, that you're reporting more accurately. And research has also shown that patient-reported outcome measures have many other problems. But if you combine it with other concepts, for example, ecological momentary assessments, that you are measuring the symptom when it's occurring, not at any point in time, so that you are measuring it when the migraine is really happening. Then you have to know when this moment is happening. And in this case, you provide the questionnaire to the patient and let him or her fill this out. Then you can mitigate the recall bias, that we do not have to recall our symptoms. And this is a real problem if you have to recall symptoms in patient-reported outcome measures. Recalling is very error-prone. And so we have to combine concepts. And if you combine ecological momentary assessments with patient-reported outcome measures over a longer period of time, then you have routine outcome monitoring. And then you have the symptoms in the most accurate way we know at the moment, in the most reliable way over a longer period of time. This is what we need. But for this, we have to distinguish these concepts very accurately. And this is often not done. I see so many publications that mix up ecological momentary assessments and patient-reported outcome measures. You have to distinguish the concepts. Patient-reported outcome measures are done with questionnaires. Ecological momentary assessments mainly with smartphones and notifications. And this must be very good, in a good way combined. If you are doing this and having a broader look at the research field, then you see that there are a lot of more concepts. For example, you have digital phenotyping coming from the Harvard Medical School. The way we behave with our smartphone, clicking on the screen, doing phone calls and whatever, this exhibits a digital phenotype. And this digital phenotype can be combined with statements or with new insights to medical questions. For example, how often we use our smartphone, there is any relationship to your diabetes situation. And there are studies out there where you can see that this can be also very powerful. This is another concept, digital phenotyping. We have so many more concepts. And if you have a look what these concepts can be used for, then you see things for disease prevention, health promotion, things like that. But you have to assign the right concept to the right goal you have. And you have to distinguish all these concepts. If you're doing this not, then often the things are mixed up. And also the acceptance by the patients is going down. Many problems in this, and this is the first thing that patient-reported outcome measures and all the concepts that are around this are not that powerful in practice as we want to have it. So you have to have a clear understanding what research is doing and what are the concepts behind. If you have a look at the literature, we have a literature review done very recently. Here we screened what I have shown to you, all these concepts, roughly 3,500 entries we found in the most important databases in the medical field, and in the end we screened 800. This is not so important information, but you see here the different questions where these studies, where you use sensors, ecological momentary assessments, and patient-reported outcome measures all over the world. So this is distributed over different questions. This is not the important information. But the important information is if you have a closer look into this 800 publications. Then I would guide you to the most important aspects of today. There are many more things that I could talk about where the problems are, but I want to emphasize 2 points. The first one is on the left side here, the days of study duration. Of all the studies you found in this 800 studies where sensors and all these concepts are used, you see that only the duration is not that long. You have here, for example, that the mean duration is only 28 days. And this is also what we can show in research, that it's very, very complicated to motivate patients to use these apps where we get all this great data, what we think about, that we get this great data, they're using it not that long. And this is not often intended by the medical experts, but often it is the case that you cannot motivate patients longer than this to use these apps really over a longer period of time. Then you see also for the sensor usage. Sensor is very important in this track here. You see here in these 800 studies, only a quarter is using sensors. This is not that much. And the adherence, so that the people are really, and the participants are really adhering to the study protocol, is also very low. And this adherence, low sensor usage, low duration times, this is the problem why we not are getting the data we want to have. And that companies that are creating digital health applications are not coming to the results they intend to have for a medical question. And now I'll give you an journey we did with all the problems and one or two more important problems we see beyond what we could show in the literature review, that are the reasons that is a very complex field to get these apps really into medical practice. The journey began for us with the tinnitus disease. And this was a very lucky situation for us that we started with the tinnitus. The tinnitus experts approached us and said, okay, we explained to you as the computer scientist, we accidentally met at a conference, and then they said to us, oh, you're doing apps. Our problem is we are tinnitus experts, and tinnitus is a phenomenon that is affecting 10 to 15% of the worldwide population, and we have no general treatment at the moment. On top of that, we have the problem that tinnitus is a very heterogeneous entity. So it differs from patient to patient. To develop new treatments is very challenging because we have so many different patient groups. And what our idea is, if using an app, then with this app, we might gather data that help to distinguish better the subgroups. And this was our starting point. And then we started 2012, the Track Your Tinnitus app. The Track Your Tinnitus app is very, very simple, and it's only gathering data. The participants register to the app, then they fill out some baseline questionnaires, then they allow some sensor measurements, GPS, and also environmental sound level, and then they get notifications, ecological momentary assessments, and when the notification takes place, they fill out a questionnaire, and while filling out a questionnaire, sensor measurements are done in parallel. The patients can also visualize their data, and that's it, only gathering data. This project is the largest one in the world in research, and you see here we have a good distribution worldwide. We have a good distribution between Android and iOS, also a problem in many studies that you also only consider one of the mobile operating systems, a huge bias. You have to always provide in studies both operating systems, but the main problem is coming or is be shown in this diagram here. You see here that most of the questionnaires in Track Your Tinnitus are only filled out, or that the participants only fill out one questionnaire and then they disappear. So that you have people that are filling out more than 10 questionnaires, more than 100 questionnaires, and more than 500 questionnaires. This is not often the case. And this can be also shown in many studies, the people that are filling out 10, 100, or more than 500 are normally those patients that think that the normal doctor cannot help them more. So these are not very representative for the whole medical population. So you have the problem only once the questionnaire is filled out and then they disappear. And this we are seeing in most of the studies. So what the literature is saying can also be then confirmed by our Track Your Tinnitus app. So then you see here also the over time, you see that we deployed it in the stores 2012, but most of the data started then by 2014 and so forth. This is also something I want to say. We are doing a lot of research because this adherence problem, so that they only fill out one questionnaire. We want to learn more. What are the reasons that the people are not filling out a lot of questions and not doing a lot of patient-reported outcome measures? Here, for example, we had a closer look in the 7 questions they are getting with each notification and trying to find out for patients that fill out a questionnaire, then they disappear, and then 30 days later they come back to the mobile application. So to get a better information, why disappearing for 30 days? And then we try to find out here, is this dependent on single questions? So we're doing this, only should show that we are doing a lot of research here because of the adherence. And the idea to get a little bit of the strategies of the patient to find out what are the strategies when coming back, when disappearing. We are not, we had a lot of publications out there, but we cannot say on a broader level, this is the reason or that is the reason. We are also trying to find out more, but I want to also show you that we are doing a lot of research here in the adherence dimension. So, but now the important information comes. Then we had Track Your Tinnitus, only gathering data. Then we started with a second app, Tinnitus Tips. And Tinnitus Tips, with this app, we wanted to improve the situation that not a lot of information or that a lot of patients are disappearing after filling out one questionnaire. And what we did with this app is we did 4 measures. The first one is we created warnings based on patient-reported outcome measures. You fill out a question in one of the questionnaires, and then if the threshold is exceeded, then we provide a warning at the smartphone saying, okay, your situation is at the moment not very good. So not only gathering data, reacting on the data the persons are filling out. Then we are gathering, also this is tips and tinnitus info. We are gathering information from research, and each week we provide in the app new information from research so that the participants get new information about research. Then 2 more measures, communication with HCP, this is the healthcare provider, so that the app has a direct connection to the doctor or a medical expert that is in close collaboration with the patient. And then we also improved the user interface. And in the end, what was coming out is, with all these measures, you see here the survival curves of the patients or of the participants. The green curve is tinnitus tips, and the blue curve is Track Your Tinnitus. And we could show that the people that are filling out questionnaires over a longer period of time and not disappearing in the first days increases or decreases with tinnitus tips. The problem, on the other hand, was all the efforts we have to put into tinnitus tips, the healthcare providers to have a look at the data of the patients, to fill it with research information, the efforts was that huge that after a couple of months we said this cannot be done longer, but we saw that with these measures we can motivate the patients much better. To make this more in numbers, you have 3 times more filled out questionnaires with tinnitus tips compared to Track Your Tinnitus. So you have to give something back to the patient, but I will show you later on this is also not enough because it's depending on the medical entity. In other cases, what we learned here from Track Your Tinnitus and from the tinnitus field, we transferred it to other medical entities, for example, to breast cancer, and it didn't work. So the medical entity also plays an important role. But here for tinnitus, with all these additional instruments, the filling out behavior and also the accuracy of what they filled out was getting better and better. So this was also not the magic weapon against tinnitus, but health literacy could be improved, patient empowerment could be improved. And so we learned that you have to do a lot within the app to get patient-reported outcome measures in combination with ecological momentary assessments really into a successful application. Important information, up to this point, 9 years before we learned all these things, 9 years. And most of the companies that are creating digital health applications, apps on prescription, do not have this experience. Then we learned more from literature. For example, the same literature review, we can show that if you are using sensors in your studies, then you can increase, not that much, but you can increase the adherence. If you're using sensors, then the people fill out more questionnaires. Then you can also use better concepts for ecological momentary assessments. There's also the concept of micro-ecological momentary assessments, that they are more clever, these notifications. Then you can also increase the the adherence to the questionnaires, and this is done by design. So not a lot of efforts have to be done. So use sensors, use micro ecological momentary assessments, but you have to be also aware of these concepts to get your app really better in the end. So, and I will show you one more aspect that is very challenging for getting data out of these apps. And this is also often not very known, but this is a real problem. I will show you the problem of the anchor effect. If I show to my lecture room two numbers, 250 and 50, and then I say, okay, please evaluate or assume how large this sequoia is here. And I have shown to one part of the lecture room the 250 and to the other the 50, then I create an anchor. The anchor has the problem that the group that was getting the information of 250 is estimating the sequoia to 2,100 feet. And the other group with only the 50 shown, they estimated to 180. And this is called in psychology the anchor effect. You ask yourself now, what has this to what is here the link to smartphone apps? There is a huge link. If you have, for example, sliders where they fill out, for example, their tinnitus loudness or their how problematic their situation, how stressful the situation is at the moment, sliders, this is the user interface element that the people often, or this is the most prominent user interface element that all people like. So if you have sliders, then you have a better filling out behavior. But the problem is you cannot create sliders on the smartphone operating systems in a comparable way between Android and iOS and without any anchor. So you have a bias in your data with a lot of sliders. And we have shown in publications that this is creating a lot of bias. But in most of the studies we see where data is evaluated and where sliders are used for patient-reported outcome measures, no one is looking particularly at the sliders, and they are creating an anchor effect. I could explain many more problems. And if you have not all these experiences in creating digital health applications without knowing all these biases, then you are evaluating data in a way that is often not feasible or not reflecting the medical situation in a very reliable manner. And here we have now 10 years of experience with the full power of experience, what I've shown only here in some slides. And then we started a new project, or were involved in a new project in Unity. Unity was a European project, and Unity was also in the field of tinnitus. And here the idea was to use existing data, this is layer 1, then do a clinical study, and in the end, on the third layer, creating a decision support system with all the existing data and new data we are creating in the largest randomized controlled trial for tinnitus ever done, to get a decision support system saying in the end, this treatment for this tinnitus patient and this treatment for that tinnitus patient. And one data source was also here tinnitus apps. In our group, we created the tinnitus study app with a very complex architecture. And what the app was doing, we had 4 modules. And mainly we did patient-reported outcome measures, ecological momentary assessments. Then we had a quiz for improving the health literacy. And we had a module where they could use a sound stimulation to mask their tinnitus, on the same frequency like the tinnitus, and then you can mask the tinnitus. And what the idea was, with the app, and in this app, all the experiences we have now over 10 years were integrated, what I have shown a little bit. And then in the end, this was the first app. This is, you do not have to have a closer look to the results. At the moment, this paper is in review. The important information is here, we were the first time an app that could show that we are able to measure tinnitus symptoms in a comparable way to a clinical instrument. But you have to have, again, be aware of 12 years, because this study also took us 3 years. So in total, 12 years of research to coming for the first time to a small indicator that the app is able to provide some measurements with the app that are comparable to a clinical setting. With all the experiences we had over 12 years, and you have these experiences not rightly considering, then this is our experience. This is very complicated and challenging to really create apps that are useful in daily practice. And with this, you have also today in this call Rainer Heinzelmeier. Rainer Heinzelmeier is the managing director of a company that is called Health Study Club. And with all these experience over 12 years, we started a startup last year. And this startup is Create the Health Study Club, where Rainer is the managing director. And with all the research results we are creating here, we are trying to get this really into practice. So this is the first project that is coming out of the Unity, what I have shown to you. And we are trying to get this now into really practice. So the product that is now being done here is called Tilencio. And the framework that is used here for Tilencio, 12 years of research. And we also have many other tinnitus apps that are available. We have to distinguish our research from them. We had a lot of discussions with health insurers, with a lot of companies. And you see also the money you need with all the things over 12 years, if you sum this up, including the medical device regulation, then there is a lot of money you need and a lot of experience. And in the end, we also cannot say if this successful is in the end. But we have 12 years of research, and this is a long time. And most of the digital health applications are created in 1, 2, or 3 years without any of these experiences. And this is the reason, for example, with too less adherence. And this is also the reason why many of these apps are not working, the digital health apps, because the patients are not using it just for one day and then they're disappearing. So you need all these experiences to come in the end to real successful applications. And even for us, it's not clear whether in the end this app is really successful or not. We will have in the app a psychoeducation module also for the commercial product, the audio stimulation, the tinnitus diary. This is the ecological momentary assessment, and also the patient-reported outcome measures. And on top of the study, we have created also a new module. This is the somatic module. This was not done in the study, but also the app is evolving at the moment. And so many experts are involved, 12 years of research. And this is the reason what I can tell you that without any of these experiences is very complex to get these apps really into practice. Then I want to also talk about the medical device regulation for this Tilencio app that is now done by the commercial company, Health Study Club. For a university, we have some developments within academia, mainly also done by the University of Aachen and Professor Röhrig and his team, and also all the people that are involved there, also from Münster. We have a lot of people that are trying also to get medical device regulation into academia, but this is very challenging. Here it's done by the company. And to give you some information for Tilencio, so the product out of Unity. The notified body, so the body that gives us the stamp in the end that we are a medical device, is done here by the TÜV Rheinland. The risk class we are aiming at is 2A. This is this is not the lowest one, so you have a lot of the documentation efforts. You see here that the technical documentation for the Tilencio app, only the technical documentation, is more than 1,000 pages. For the quality, QM documentation, quality management, you need also this. For the risk class 2A, then we have more than 500 pages. And this is completed. We have with the TÜV Rheinland, we have the documentation already completed. What is only missing at the moment, an on-site inspection, so that they're coming to the company and having a look at our practical things. And then at the moment, we estimate that we get an approval for risk class 2 medical device regulation within the next 3 to 4 months. Some more information. For getting the TÜV Rheinland as the notified body that is able to give us the yes in the end, we started our research for one of these companies that can do this in the middle of 2022. In the first half of the first 6 months, we only get rejections. Most of these TÜV Rheinland and many other of these institutions are heavily overloaded, so they cannot say, okay, we can go with you for a medical device. And they had also no look at our project. They only said, we are overloaded, we cannot do it. So then we found the TÜV Rheinland in the first quarter of 2023. And what was the reason? And this is also the question mark here. What was the reason? The reason was that we, for the first time, had a better direct look into our documentation with the TÜV Rheinland. And they said, oh, you are very different to many other projects. You have so many things already done. It could be that this is going faster. So you have to have a good documentation and a good idea how to communicate with these institutions before you start really the approaching of these institutions. Then we had 2 rounds of personal meetings. And after this 2 personal meetings, then we had some ping pong via email. Then they said, okay, we will be the institution that are going with you through this process. Our quality management system was then submitted 1.5 years later at the end of 2023. The technical documentation submitted February this year. And for the documents, we have the stage 1 passed. So the notified body is saying at the moment, okay, you passed for your documentation, the things. The next thing is the on-site inspection. And then after this, you will get the approval for risk class 2A medical device within the next month. 12 years of research, creating a company, 2 years of medical device regulation. You see what the efforts are. And this is only for tinnitus, and what you need in the background to really come to a situation where you feel very good or you feel comfortable in bringing this into medical practice. And still for us, we will see in the next years if this is really successful. The notable points are here that with a good consultancy in the quality management, it is not possible. So we had also external help. Then we had our clinician by the side convincing the TÜV Rheinland that the study is really reliable. Then the study size, often the study sizes are not enough for the medical devices. And the costs in the end will be roughly 50,000 euros. So this is also only for the whole process of the medical device. So you see, this is also again costly. The 4 decisive aspects here, we would say, if you ask the guys and also Rainer from the company, validation documents, study documents, so that the study is really, the Unity study is really well documented, that the study has power, and that the software development is really adhering to the medical device regulation. And I can only say the medical entity plays a role. This is for tinnitus. We transferred all the experiences to another study where we are working on breast cancer aftercare and the mental situation. We transferred all the results and it not worked. So the population for breast cancer aftercare is really behaving in a very different way. New experiences. So you cannot transfer this easily from medical entity to medical entity. This is another experience we made. So, and this is our hypothesis. These are the reasons why at the moment many of these apps are not working also in clinical practice. Then very shortly, I've already used a lot of time. But I will also show you in a very quick manner one project that is showing what are also the problem with sensors at the moment in our the experiences we made with sensors in this particular project. The acronym here is what is behind this. This is the 6-minute walking test. The 6-minute walking test is often used in cardiology, and the distance you walk within 6 minutes is a very good indicator for your health situation in general and also for your cardiac situation. So in our ambulance, in the heart comprehensive heart center in Würzburg, many of the patients are doing the 6-minute walk test. And in a very long-running study with over 3,000 patients, also Würzburg was able to show that the 6-minute walking test is a very good indicator for your cardiac situation. And then our cardiologist, our main cardiologist, Stefan Störk, approached me with the information that we are doing a lot of apps, asking me, hey, why not creating the 6-minute walk test with an app? In our ambulance, there is a study nurse beside the patient and measuring the walking distance in a very manual manner. But that could not be the way we should do this. This must be done with smartphone apps. What we did then, we did a literature review. We found this literature here. We found also something from Apple, that the Apple Watch can also do the 6-minute walk test after training of 6 weeks, the machine learning within the app. So after 6 weeks, the Apple Watch is also getting accurate information about the 6-minute walk test. And then the cardiologist is saying, yeah, okay, 6 weeks, this is not practical in daily life. So we need something quicker. And also the thing I'm showing on the top is older and is not what can be very easily used in practice. Then there is a recent publication. They did it also only on Android, but this is the first one that is a little bit getting better. But this is not something abroad that can be used as a broad instrument, what they did here. And then we asked ourselves, that cannot be that the 6-minute walk test to measure with a smartphone, with all the sensors, this just 6 minutes walked distance. Then we had a look at the stores, and you find, for example, this app here, and this app is using, sorry for that the text here is only in German, but they are measuring it mainly with GPS. But GPS is also not a good idea, but then you can also provide the test outside. Many cardiologists, like in the ambulance, want to provide it inside the building, so this is also not feasible. And then we started our own app, and also Rainer, that is here from the company, that was done by the company. And we created the 6-minute walk test here on Android, and we also created it on iOS. And if you download this app at the moment, we created the 6-minute walk test, we think in a good way, in the best way at the moment. But you also need a very complex calibration procedure. And this is shown in the video here on the right side. We have not the time for the video, but before you can walk, you have to do a very complex calibration procedure. If you have done this calibration procedure, this is needed for calculating your distance you walk with one step. And then we had created a new algorithm that is able to measure comparable between Android and iOS your walked steps. So we are very accurate in measuring the walked steps. This can be done, but to get for the walked distance also the length of one of your steps. Therefore, we need a very complicated calibration procedure. The basic idea is here also to develop this algorithm for getting a very precise step counter between all the different smartphone apps, Android, iOS. If, for example, you want also use a watch, this only shows that we had a long period in the ambulance where we created our apps and adjusted our algorithm for the step counter, or for getting the step counts in the end for 2 months. So we adjusted the algorithm again and again and again to get a very precise step number in the end, or step count number in the end. So the approach is more or less brute force to get a lot of data. But the step count is now very accurate. The length of one step, we need a very complex calibration procedure. And we are working at the moment creating our own sensor. This is our next idea, beyond or on top of the smartphone, to get the test more accurate. But that simple test is not cannot be easily done at the moment with smartphone technology that has more computational power, like for the moon landing. And you see here, and this is also our experience, that the first thing I want to say is the remarkable thing is also I want to do a comparison. Our questionnaire apps here, for example, an app that is used in the context of challenging child behavior called Provia Kids. This is very representative. We need 8,000 lines of code for a very complex questionnaire app. And for this simple measuring of distance, what I have only shortly showing for the 6-minute walk test, we need 24 lines of code, so that it is comparable between Android and iOS. And also what the efforts you have to do on the smart operating systems for sensor-based, comparable sensor-based apps is, and you can also make more errors with more lines of code. So these are all reasons that in the end, our experiences are in many cases that smartphone technology is still a long way far from being to use in daily medicine. There are often examples. We see that in a very particular dimension work, but on a broader level, and also all these fitness. We had also a lot of studies with fitness trackers from our experiences far away from being used in clinical practice. And this can be also very in our eyes impressively shown by the 6-minute walk test. In the end, I can only say from our experiences, on top of what I've said, that or I already said this, but the medical entity plays an important role. What is working in tinnitus, there is no one saying or that you have no guarantee that it's working with breast cancer or with diabetes or whatever. The medical device or the regulatory affairs at the moment play an important role more and more, and it's challenging to adhere to them. Also, the comparison between Android and iOS, so that it's comparable what you are doing between the different operating systems, and you have to provide both. If you want to use it on a broader level, is often underestimated. Digital questionnaires or to provide paper-based questionnaires on smartphones is that complex, and it's often underestimated. And we have also shown in a literature review that the tool support worldwide, so that you have free tools to create apps, I have shown is at the moment also not very good. So you have no toolboxes that you can download freely and start with your own app. Often you have to do this on your own with your own experiences without any generic support. And this is also a reason why we think that the clinical practice is often far away from that these apps can be used in daily life or clinical life in a reliable and also evidence-based manner. So this is the literature we did here. We found on GitHub 400 tools, and in the end only 6 remained. And if you have a look at these 6, then most of them are also outdated, just to give the information here. So tool support is also not very good in a generic manner. So this is the reason for us why we created or started the startup called Health Study Club, where Rainer is the managing director. And here you see a video what the Health Study Club is doing on this link, and also where you can find more information about the startup. This is our answer for the moment, that many of the things can only be done in a company and not in a broader or on a broader level in only in the university. If we will be successful, we don't know, but this is what we have done also in the last 2 years based on all the experiences we made. So thank you for your attention.
Thank you very lot, Professor Pryss, for this great presentation. Yeah, it's really fitting very well to the experiences we made in discussing with companies. For example, in the last year we had one company which as well discussed the challenges to get medical device regulation certification. plus then the experiences of the DIGA. And I'm very grateful for you that you discussed it that openly, because the last video we could not present or share at the end due to whatever. So that's a great content, great overview. I agree with a lot of things, but let us first see in the auditorium, are any comments or questions in that regard? And you again have like two possibilities, either use the chat or activate your mic.
So, Andreas speaking, hello. Also, thank you very much for this really good talk. My question would be, because you're commercializing the app, of course, and you're going more or less like also into competition then. Obviously, as Sebastian just said, we had already some DIGA talks last year in this series. So are you also aiming at a DIGA certification, so to be able to prescribe that, or would that be the business model, or do you have another idea to I mean, if you start a company, you always have to have an idea how you can make money out of the product, right? I mean, otherwise it's a social engagement, but not like a company, right? We all know that.
That's a very good question. Perhaps Rainer can comment on this also. He is talking a lot to the health insurers at the moment, and also to a lot of groups, institutions, what will be the ideas or targets to commercialize the thing really in the end. We are not aiming for a DIGA for the moment. The reason is that when talking to and we have a lot of other apps that we are also developing at the moment, and also for them, it's not intended, or the idea to make them as a DIGA. The problem is that with all the costs you have, and also for the DIGA, then in the end, and also with the levels that are out for the DIGAs, for example, that you have a lot of examples where the DIGA is costing in the end for 1 year more than 1,000 euros. And the health insurers are saying, okay, we do not know, and this is easily understandable, we do not know whether this is really working in 3 years for all of our patients. Why putting so much money into a DIGA? It's better that the apps are cheaper, and that, for example, we do some contracts only for one health insurer, and they are providing this then for their patients, so that you have another broader thing. So they are called Selektivverträge, so that the health insurers are doing it only for their patients. This is our strategy for the moment, because we learned that then the health insurers are much more willing to really discuss whether they are used. We do not know whether this is a good strategy, but for the moment, Rainer, I think from most of the discussions, it's more going into the direction of Selektivverträge, right?
Yeah, that's right. There's really, thank you, Rüdiger. Nothing much I can add for that, but our approach is not to go the DIGA way, because also the regulatory requirements for DIGAs are extremely high, and which does reflect in the price points, and the high price points are kind of in the way to be commercially successful. So what we try to do is also that we have new business models and billing mechanisms we try to discuss with the health insurers, just to utilize the scaling effects of a digital product. If you compare it like to products and services in telecommunications, like people my age can remember that you were paying for local calls per minute. And if you look at the market today, it's completely different. You have flat rates all over, and I think you will also need to apply these approaches also in the realm of e-health applications, that you will that you can engage as many patients as possible. And not have this pay-per-use aspect that you treat a digital product, a digital treatment like a box of pills, basically. And so we try to have a different approach doing that. And I'm in a lot of talks and discussions with health insurers at the moment. And they are, at least that's how I reflect on it. They are very eager to have new approaches, and but it's like, if you know German regulations, it's also very complicated. It's not easy, but I think we have a good chance to have a new and a different approach and do something. Do things different than the competition does it. And so DIGA, to come back to that question, is not the approach we have at the moment.
Yeah, thank you very much. Very interesting. Yeah.
And maybe to add on that, so the experience of other DIGA suppliers are as well, like you need a huge team to handle all this extra effort. Which then might require to have a stronger venture capitalist or at least money flow included in the preparation. Yeah, so that's fitting really well. What I as well think is interesting into that direction is that we recently analyzed how many of the DIGA companies are using external sensory as an additional mean. And it's rather small, so I think it was below 5 companies at all using external sensors. So that might indicate as well a challenge of the DIGA regulation in that regard, which we could discuss further onwards, because I think so the sensor usage aspect seems to be highly relevant considering the acceptance and adherence.
This is the case, yes.
So do you see a reasonable chance in the way to integrate external sensors into future medical device regulation based products?
I think it's heavily depending on the again on the medical entity, but for example in diabetes, with all the glucose or the measurements here, the possible measurements here is a good situation where external sensors might be beneficial. And also with all the where you have cardiac problems, so that your health situation is measured by whatever surrogate. So whether it's the heart rate, or it's the blood pressure, or it's the 6-minute walked distance, whatever. So also here I see very good opportunities. But again, we have to have a very comparable situation, so that an Android user is have the same situation than an iOS user. And these things have to be really considered. But I think it's getting better. And the mobile operating systems has also learned that you see this also, that they opened a lot of API calls that were not open 5 years ago. So they also learned we have to make it more comparable, so that on the one hand, iOS is providing something that Android not, or the other way around. So it's getting better. So to really answer the question, good opportunities in the next time. But you need, again, a lot of experiences. And if you have them, or you have to make them and fail, but then it's possible.
Yeah, I would agree, totally challenging risks as well, right? Shipping a sensor to the user, not only an app. then regarding the willingness or motivation of the users to recharge regularly the devices, to keep it connected. On the other side, you have higher reliability in the signals, right? Because you have the same sampling rate, it's always placed at the same position. So yeah, we will see. Are you preparing a product where you really want to invest? So this 6-minute walk test right now, it's, you said, app-based, but are you intending to add a sensor and certify it?
No, yeah, this is our plan, but only doing research at the moment. We have 3 ideas for a sensor. The first one is that we measure with beacons the distance within a room. So based on this is the first idea. And then also with a combination of machine learning and a sensor on the food that is measuring things. But this is in the stage of research. I think from now on, 1, 2, 3 years, when we have really a practical situation, then in the end. But this is a concrete plan to develop a sensor that makes the 6-minute walk test that we can provide it in a really reliable manner, and also that can be used on a broad level, so that everyone can use it and see how the distance they walked in 6 minutes, that it's very precise. And you have many more problems. For example, for GPS, if you're doing it outside, the 6-minute walk test is only then reliable if you walk in a flat way. If you have some altitude, then it's again not reliable. So you have to consider so many dimensions. So we have to consider a lot of confounders at the moment and parameters. But I think it is manageable. But 2 or 3, 4, whatever, more years researching.
Yeah, we might even have different versions of the test, to have like a professional version with certified hardware. So not only the sensor, but also that it is that you have certification for special phones and that you have to use. And that would be an approach to use that in a professional environment. And do the test, and then we are of course working on a solution which is purely app-based and would be like a consumer version of the product. But there's still a lot of things to evaluate and a lot of research we have to do. But I think it would the business outlook could be very compelling.
Thanks a lot. Any other questions? Okay, so in that case, let's call it a day. Thanks a lot for the great presentation, and hopefully we will meet again at the panel at GMDS in Dresden.